Hello, everyone. Thank you for being here. My name is Heather Hitchcock, and I'm the Chief Marketing Officer at Medical Informatics Corp, founders of the SickBay platform. And today I am my esteemed colleagues, Amber, Dr. Vaja. We're so grateful that he's here. And we really want to kind of sit down and just talk a little bit about, we all know that we've had a lot of challenges in healthcare, right? I mean, the staffing is not going away. There was a recent article that talked about 100,000 shortage over pandemic and about 800,000 that we're going to have a shortage by 2027. And that's just RNs. So we really need to come together and look at different ways of looking at healthcare and looking at how we can really create a new standard of data-driven care. So before I begin, if each of you, my colleagues, if you could just give a little background of, Start with you, Eddie.
Sure. My name's Eddie Vadia. I'm a pulmonary critical care physician. I co-founded a telemedicine company back in 2013, 14 called Access Physicians. Grew it from inception to acquisition in March of 2021 and have been working closely with you guys since. It's a pleasure to be here. Thanks for having me.
Hi, I'm Amber Glauser. I am a solutions architect with Medical Informatics Corp. Also by trade, I am a registered nurse. My background, I have over 15 years of experience in designing software applications in healthcare. So thank you all for joining us today.
Yeah, so I want to start, Eddie, with let's talk about, when you look at virtual care, right? Secondary monitoring has been around forever. If you look at central telemetry, that's all well known. We all know that the more eyes on the patients, the better. And in many ways, it kind of started with providers, with you creating Access Physicians. It's really what drove us, even at Houston Methodist pre-pandemic, looking at provider coverage. Providers can't be two places at once. We've got challenges overnight. So tell me just a bit first to set the stage, that journey, what led you to Access Physicians, and and where you think it might be evolving.
Well, I think the hardest thing to do in healthcare is scale clinical excellence, right? It's why universities don't scale beyond their zip codes. Okay, it's why some of these major institutions like the Cleveland Clinic have satellite clinics, but they're very few, far in between. And so we were challenged with. We had a challenge of actually scaling elite physicians to smaller communities. We decided to sort of rally an initiative around that, i.e. the company, and we put everything into it. And Access Physicians ended up having seven to eight mature clinical service lines, from maternal fetal medicine to pulmonary and critical care, which is what I do for a living. And we were able to deploy at over 250 hospitals across 30 states. The interesting thing, though, and I think Amber can really sort of talk a lot about this, is that the technology ended up being the easy part, right? Building, a well-designed clinical program, I think, was the tough thing. And then scaling humans through technology, I think, really became an even bigger challenge. Amber, I don't know if you agree with that as a nurse.
Yeah, definitely. I think we have a lot of work to do in healthcare tech specifically, not so much about deploying excellent code, but really looking at how do we marry that with the people and the process that supports that. And ultimately having that triad all accounted for helps us to really identify and target improving outcomes and reducing the cost of delivering care as well.
Well, Amber, it makes me wonder too, right? So we talk about providers. That's a driver. You look at telemetry monitoring, you look at virtual ICUs. Why do you think those haven't scaled? I mean, it may be the only answer, right? Virtual care, we've got to look at it. But why do you think in this time and age, why have we had difficulty scaling those secondary monitoring solutions?
This is an answer with a lot of complexity. So there is some technical limitations historically of the way that it's been approached by hardware manufacturers, one piece of it. Just as Dr. Vadia also mentioned, we do also have a crisis in being able to actually staff a lot of different areas within healthcare. So thinking about the rural healthcare facilities that are in crisis as well, and how we're looking at how that has impacted some of the closure of those hospitals too. So being able to serve populations requires, of course, people, but also the appropriate technology to support those different models to make sure that we're reaching far into those undersupported areas or communities as well.
Yeah, I mean, Eddie,
I'll just add to that too, if you would. I think that two things. To your point, I think that great providers, and by that I think in that definition, including physicians, nurses, teletechnicians, respiratory therapists, etc., are hard to come by, right? And I think that there should be a quicker scale than you've been talking about historically, because I think that there's an opportunity for large systems in particular to create centers of excellence in whatever area of interest. I also think we've done a particularly bad job in making the financial case to move towards what you're talking about, right? And I think that's what I spent the last year trying to understand and do and deliver on. So there's a big clinical component here, there's a big operational component here, but there's also a big financial component here. And all these things have to come together, right, to actually create true initiative.
And when you think about going beyond, you mentioned a lot of other care providers, right? I mean, we see a lot of things in the respiratory therapy space, the central tele space, right? The staffing shortages are not just there. And when we look at ventilators, I mean, that's something that ventilators only alarm in the room. I mean, we've got a big problem there, right? And so we've got patients that are acute in the ED. They might be on a ventilator. So where do you see the evolution? Yes, we've had virtual ICUs, but I think what we've been getting to see is that a critical care patient could be anywhere. And we're starting to talk at home too, right? Right. So where do you see the vision of virtual care models going?
Well, I think that there's going to be, we always talk about hospital consolidation, systems consolidating, right? And I think everyone's, to some degree, is going to be consolidating on excellence, right? Look, not all providers are made equally, right? And so you want to be able to not just scale across geography, but between units within systems, right? And so to that end, I think you want to scale your most excellent providers, right? And I think that's where we're going to be moving, right? And I think that there isn't a lot of market ready solutions right now to do that. Right. And I think that's part of the reason why things haven't really gone as quickly as we'd like it to go, because the technical market isn't ready until now. Right. And so we've hit critical mass, and I think MIC is part of that sort of initiative.
Yeah. And Amber, you talked to a lot of hospitals about kind of the disparity, because part of it is, look at all the mergers and acquisitions. Every single week we're looking at, they're buying another hospital, and all of a sudden now you don't have the same EMR, you don't have the same monitoring equipment. Like, what do we do to kind of break down that disparity, the disparity in workflows? I mean, these are some of the things that you advise a lot of clients on. So if you have any advice there.
Yeah, absolutely. Across health systems, there's always going to be complexity of different tech players in the mix. There's going to be different vendors that have specific agreements, which make it difficult to get out of those types of situations or contracts. And that's okay. I think really the position we have to go for in the future is being agnostic and being able to be flexible in healthcare. And that allows us to be agile in our business initiatives. So we all witnessed that through COVID, of course, the need to quickly pivot, change our business objectives, and need to be able to change our delivery models as well. So the key to that is really looking for systems that are flexible and are looking to scale as well, without having to go through the traditional process of how do I unmarry from a hardware vendor, for example, because again, that can be extremely costly and time consuming as well.
Yeah. And when you look at, we think of these big hospital systems, right? So I'm going to turn to you, and then I want to pivot to Dr. Vaji again. But like when we look at a 50 hospital, 50, 100 hospital system, when you're looking at the underlying technological architecture, what is that, what's kind of your advice? You're one of our resident cloud people, and there's on-prem, there's hybrid, there's at the edge. Like what are some of the things that you look at there?
Sure. So historically, healthcare has leaned heavily with on-prem deployments. And a lot of that had happened with the immaturity of cloud services up until this point. And so from our side, we believe that being flexible is the first most important way to approach being able to deploy technologies. So having the ability to install on-prem is one way of supporting customers. But then just as we all saw with that supply chain breakdown that happened again during the pandemic, we realized that we also have to be flexible and to be able to do just-in-time deployments as well. So a way that you can do that at large scale is by using cloud compute, which is exactly the initiative we're working at here with Dr. Vadia as well. So being able to adapt to any infrastructure is also really key for a business. So saying whether it is traditionally on-prem, a hybrid model, or a fully cloud native solution, that really allows the flexibility of the healthcare, the provider space to be able to deploy in whatever way works best for them and their security protocols. With that being said, there's one major advantage though, and we want to talk about is the next stage of not just watching our patients, which is what we've been focusing on in this conversation today too, but really getting to the next level of analytics and deploying large data models, which we know that cloud compute is the best at being able to quickly process these massive data sets to give us valuable insights, which can now create the landscape for having tools to provide predictive analytics and care. So now not being so reactive, but looking to be more proactive with our patients and having technology enable all of the insights that we can gain from using those large amounts of data that we're gathering through the day-to-day clinical bedside care.
Awesome. So Eddie, can we shift to what you're working on now? So you're doing a lot of strategic advising after obviously as a physician, as looking at one of the first staffing agencies in the country. What are you working on now? What's some of the big projects and where do you see that going? Because the other thing that we hear a lot of as we look at virtual care as maybe the only way to scale, there's also this idea of who does what, right? I mean, we've heard nurses that are like, oh my gosh, their big brother, they're watching over me. So there's also this idea of what do we need to do to shift the culture and to also enhance the adoption.
Yeah, and just to talk a little bit about our project together, I think that the telemetry space is something that is it's in its infancy. And, in our project, we're trying to consolidate a large employment burden at a fairly large health and hospital system. But it's not just the employment burden, it's ineffectual care associated with telemetry techs. And, there are fantastic telemetry techs, but what I didn't know it was an expensive and high turnover position. I did not know that. And when those telemetry techs call in sick, in this case, 30% of the time, they get replaced by RNs who are, 5 times the cost. So what we're trying to do is do two things: is to eliminate the burden of employment, right? So consolidate costs, but also improve quality, right? By centralizing a very, very important skill set for the organization. And so that's what we're doing. We're consolidating the telemetry techs that are now found local regionally, pulling them into, let's call it a headquarter, right? A bunker, and distributing the best of them, their excellence across the entire enterprise. We plan on reducing the number of tele-technicians. It's always a little morbid to talk about that, from about 70 techs to 18 techs. Plan on saving over 50%, and also plan on improving outcomes. And so I think that when you start thinking about healthcare, if you can save money or generate revenue, but then couple that with an improvement, not just a non-inferiority, but an improvement in care, I think you're onto something special, and you guys have helped make that happen.
Yeah, I mean, I think you do a lot of work on the ROI. As much as we don't want to talk about the economics, it's part of this mix, right? The financial solvency of hospitals is just as bad.
Yeah.
So
if you can't look at, let's be very frank. Healthcare executives have money on their brain, and I think that you got to capture them. Unfortunately, kind of have to capture them that interest first, because it creates viability, right? Look, I think we talk a lot about money and executives. Look, at the end of the day, what executives are they've got to take a project and they've got to sell it to their team, and to do that, you have to create sort of a viable pathway to existence, and that's through the financials. Unfortunately, it is what it is. But you got to do that essentially first, and then build around that.
Yeah. Amber, before we kind of close out here, we talked about AI and ML. Everyone talks about it. Where do you see it? We've seen models where when you start to integrate analytics, real-time analytics into the mix, you can then have one VRN or one VRT or one teletech. You start increasing the ratios, right? So tell us a little bit about kind of the importance of AI. The essence of the data itself and how that's important, because a lot of AI hasn't got adopted. You've looked at things, it's no better than flipping a coin. So just if you can tell from a clinical side and a technology side, that would be great.
Sure. And anyone that wants to talk about AI, I'm happy to chat about all day. It's my favorite topic. However, from the nursing perspective, a lot of times AI is a dirty word. It's perceived as the thing that wants to take their job away, and we have a lot of challenges around adoption. So helping to break down exactly what that means actually for the nurses, it means that we're not getting rid of nurses. Our patients are getting sicker and they're living longer. So it's really about how do we make sure that the nurses are supported by technology to be able to focus their attention in the places that they are needed most at the time they are needed most. So being able to have automation around my patient prioritization, making sure I'm focusing where I need to, and then supporting the nurses through different other various clinical activities wherever automation can be deployed. So looking at actual detection of events prior to them happening also allow for the staff team or the multidisciplinary team to adequately prepare, have the supplies they need and the appropriate staff to help reduce the potential for those adverse events or adverse outcomes that we see all too often in healthcare.
Great. All right. I want to make sure there's time for Q&A. Any last closing remarks before we kind of, adjourn? We will have time over here if you want to meet with Amber or Dr. Vaja and learn a little bit more about some of the technology. But any closing remarks? Any last minute advice as everybody embarks on this journey? What do you say? Grit.
Grit. Build the financial model, build the operational model, and everything else will follow.
Okay.
Those aren't technical things,
No.
right? Those are just human things. So that would be my advice.